Now, you mentioned earlier there was, we're going to switch now and talk a little bit about our ibrutinib combinations or BTK inhibitor combinations. We talked a little about CD20 combinations. You mentioned some data that perhaps with obinutuzumab, the depth of the remission might be different. Can you elaborate on that at all, or what's your sense of that?
So, in terms of comparing rituximab and obinutuzumab, these are two very different antibodies. Obinutuzumab is a type 2 glycosylated CD20 antibody that really can target CLL cells directly and kill them. It doesn't rely completely on antibody-dependent cytotoxicity, although it can certainly kill by that mechanism too. And one of the things that's been seen with ibrutinib and rituximab is there may actually be some antagonistic effects because ibrutinib has a number of off-target effects, including inhibiting ITK, which can be important in natural killer cells and antibody-dependent cytotoxicity. So I think we can't assume that because ibrutinib and rituximab are not working better together than ibrutinib alone, that the same is going to be true for obinutuzumab combinations, including with ibrutinib. So I think it's going to be very interesting to see. And unfortunately, the Illuminate study doesn't help us there. There was no ibrutinib-only arm. So.
Yeah, it really wasn't designed to answer that question.
Right.
We just saw this, relatively recently, the New England Journal publication looking at the combination of ibrutinib and venetoclax. John, is that data looked pretty good, pretty exciting. We're going to go through some of the different combinations, but what do you think about that?
I think the data is very exciting. I think getting to a state of undetectable minimal residual disease, which you can get with these combinations, and in particular this combination of ibrutinib and venetoclax, BCL2 inhibitor, is an important endpoint for not all patients, but a large number of patients, and particularly because it leads us to the ability to stop therapy. One of the unappealing things for many patients who are taking these oral targeted therapies, as Brad's alluded to, is this long duration of treatment. Now, of course, it's doable. There are people who've been on ibrutinib for almost 10 years now, actually, and doing very well. But it leads us to this scenario of maybe what we've seen in CML. Now, I'm not sure we're ever going to be able to achieve those kinds of results with the targeted agents that we have in CML, but the idea of stopping treatment is very appealing. And we do understand that if you're MRD undetectable, and maybe you can get there with a combination where you can't with a single agent for most settings, that leads likely to an ability to stop. We'll have to see over some time if you can re-challenge patients and then, of course, get another subsequent remission or response, which I think in most patients you likely will unless they have high-risk features. But I'm very excited about the combination therapies in the right patients. But I say that specifically because I'm not sure you have to become MRD undetectable if you're a patient who is, like you alluded to, an 80-year-old patient where really it's still a palliative situation. We're not curing those people, and we're trying to keep them happy and healthy and out of the doctor's office for as long as possible.
Brad, what do you think about Mrd negativity and maybe even some of the definitions, the different compartment effects sometimes we see with the CD20? Is that a valid endpoint today? Should we be doing something different if someone's MRD positive or negative after the therapy?
It's a great question. There's a lot of unknowns there. Obviously MRD is just another way to measure the depth of the response. So an MRD negative complete remission is presumably better than an MRD positive complete remission. And the big question is whether those sort of measurements would allow us to give the therapy in a time-limited fashion. Or in other words, does it give us a rational stopping point for some of these indefinite therapies? There are a couple of very important ongoing trials, one of which could help answer this question. There are many trials looking at this question, but I just want to highlight a U.S. intergroup trial led by the Alliance for older CLL patients, and patients are randomized to the combination of ibrutinib and obinutuzumab versus ibrutinib, obinutuzumab plus venetoclax. So it's taking the three very best agents that we have in CLL, putting them up front, adding the third agent for one of the arms, and then patients will undergo an MRD assessment at some point in therapy. Around a year, I believe, and for patients who are MRD negative, they then have a discontinuation strategy, whereas patients who are MRD positive have a continuation strategy. And for the MRD negative patients, there's actually a randomization to continuing or discontinuing. And so I think that trial and trials like that will be very helpful in us sorting out how to use MRD to help determine duration of therapy.
Yeah, I think that is an important. There are a number of trials that are looking at those discontinuation and whether you can stop therapy or not. It seems that most of those studies, Matt, when they include venetoclax, right? I mean, it seems like it wasn't really till we were adding venetoclax that we were getting to the level of undetectable minimal residual disease. And yeah, you've done a lot of work with venetoclax. Your thoughts?
Yeah, I mean, I think that the validity of the MRD endpoint really depends on the therapy. So if you're looking at ibrutinib as a monotherapy, it's not really necessary or valid to look at MRD because patients can be in a PR and do very well for many years on ibrutinib monotherapy. And so if you're doing continuous therapy, you don't need to worry about it. But if you're doing time-limited therapy, that's where I think it can be helpful. Although I'll add that I think this is still an unanswered question. So I think we're going to talk in some more depth about some of the venetoclax combination data where they actually designed a time-limited regimen based on just every patient getting the same duration of therapy. So 1 year in the frontline setting, 2 years in the relapsed refractory setting. We don't know yet if that's going to be feasible or whether we need to be measuring MRD, as Brad was saying, and then guiding therapy based on that. So I think both strategies need to be explored in trials, and that will hopefully help settle that question. But clearly, when we're using venetoclax-based therapies, we can get to these deep MRD undetectable responses, and I think that really provides an opportunity to discontinue therapy and hopefully have a good durability of remission after that. And as John was saying, hopefully be able to then subsequently retreat and get response again.